So good afternoon, good morning, good evening. Welcome, ladies and gentlemen, to this webinar entitled Pandemic Perspectives, Addiction Science in the Era of COVID-19. My name is Niamh Fitzgerald. I'm a professor in the Department of Psychology at the University of Johannesburg, and I'm also a member of the International Confederation of Alcohol, Tobacco and Other Drug Research Associations, ICARA. We send you a warm welcome to this webinar series on COVID-19 and substance use, and we really appreciate the time that you've taken to spend with us today. So this webinar series is being hosted by ICARA and also the Department of Psychology at the University of Johannesburg. During the next 6 months, ICARA is going to be hosting a series of webinars on COVID-19 and substance use, and today is the first webinar in this series. We'd like to express our gratitude to the sponsors of this webinar, the Society for the Study of Addiction, who very generously have provided support for this webinar. We're most grateful to them. Finally, before we start, I'd like to just express our gratitude to the University of Johannesburg, the library team, and all of the members of the library who have been instrumental in making this happen. So thank you very much. Before I start, I'd just like to go through a few instructions about how we hope to run this webinar today. So we ask you all to please remember to keep your videos off during the entire period of the webinar, just to make things run a little bit smoothly. We also ask if you can please keep your mics muted, unless of course you're speaking. So we expect the speakers to unmute their mics, but at other times we ask that you all please keep your mics off. If you want to ask questions, we have an opportunity for people to ask questions via the Q&A. So you can write down your questions, and the chair of the webinar will be able to see your questions and ask them to the speakers. And at the end of the webinar, we ask one final request of you, which is to fill out a feedback sheet, which you'll receive. This is a series of questions, well, just 2 short questions asking you for feedback on the webinar. But apart from that, we welcome you once again, and we hope that you'll enjoy the webinar. We have a fantastic panel, we have a fantastic chair, we have a fantastic discussant, and we really hope that you'll enjoy this afternoon. So I'd now like to hand over to Professor Niamh Fitzgerald, who's our chair. Thank you, Niamh.
Thank you, and good afternoon and good morning, wherever you are in the world. Good evening. You're very welcome. Thank you, Niamh, for that lovely introduction. I'm going to just talk you through a little bit about what ICARA is, but I will just bring up my slides just now. So it's fantastic to see all the numbers popping up in our attendees. Just on this introductory slide, I just wanted to mention that you can tweet during the webinar series, during this webinar. So our hashtag for the webinar is ICARA webinar, so easy enough to remember, but you're encouraged to do that. I want to tell you a little bit about ICARA. So it was established in 2011. Professor Tom Babor was one of the founder members. It's an umbrella organization for research or for other research organizations. So we have members that are societies and associations of researchers across the world that are focused on alcohol, tobacco, other drug and behavioral addictions. And our mission essentially is to promote, support and enhance research on these topics nationally, internationally, through professional exchange, collaboration and other activities. And we have a very deliberate focus on capacity building. We believe in the value of peer-to-peer learning, both within and between countries. And that's a real focus of our activities. We're non-governmental. We are not aligned to a specific discipline and recognize the value of multiple disciplines and multidisciplinary work in this field of research. And our members are primarily organizations, although there is a facility to join as an individual if you wish to do so. So just to give you a flavour of where we are currently represented, our membership, and I'll show you the list of members in a moment, is spread across multiple continents. We have in the past had members also in North America and Asia, but now I suppose our membership has been evolving and we've seen quite an increase, particularly in international organisations joining and also in national associations in Europe. So if you're from outside of those areas, you're particularly welcome to express interest in being part of ICARA, and I'll talk a little bit more about that in a moment. So you won't be able to absorb all of this in the time I'm going to leave it on the screen, but it was really just to give a shout out to all of our members, several of whom are curating other webinars in this series. And just to give you a flavour of some of the international and national organisations that are full members of ICARA, but also to note that whilst full membership is open to associations and member organisations in this field, our associate membership is open to research teams, institutes, consortia, centres, and other organisations that don't fit that sort of main criteria. And we do have a good selection of those as well. So if you want to get in touch, if you're not already a member of any of these organisations and you want to find out more about them, you can go to our website and we have a member directory there with a named person for each of our members and a link to their own websites. So why do these organisations join ICARA? I suppose one of the main reasons is that they can access a global audience. So whenever they themselves as individual organisations are organising, whether it's webinars, conferences, training initiatives, or even advocacy letters and campaigns, they can, through us, disseminate that to other organisations and reach that global audience that they may not always have in their own membership, and therefore attract people to each individual association according to their interest. We also believe strongly that our member organisations share common challenges and that there will be common solutions for research societies and teams. Excuse me, my children have just come home from school, sorry about that. We organise workshops and symposia in partnership with our member organisations, so we tend to join in their conferences. Obviously, this webinar series is a new thing for us, but we're really excited about it. And normally every 2 years, but with a slight delay for our next one, we have a general meeting, which is like our own mini conference. So we will be having that probably online later this year. And that's the topic focus. We do also work on issues of shared challenge. So we have produced guidance that may be useful to some of you on managing relationships with commercial organisations or other organisations where there's a potential for conflict of interest. So that is guidance on how you might develop your own policy for your organisation or team rather than telling you what to do. And it has been found really useful, I think, for others. So I suppose fundamentally, ICARA is an organisation that believes in the value of bringing researchers together to discuss and share their values and interests. And so we are conscious that not everybody might have this opportunity. So, we're really interested to hear from you offline, after these webinars, if we pique your interest. Do you already have a network or research association either in your country where you can get together with colleagues who have similar research interests? Do you have opportunities to get together with other active researchers or teams or institutes? And of course, many countries do have national associations or other networks, and some of them are members of ICARA. We really welcome them as members. But we're also conscious that not all countries will have that infrastructure, and we'd like to help. So if you are an individual researcher out there and you know that there are others that you would like to link up with, perhaps in your own country, but you don't yet have, say, a national association or a network that you can do that, then we're really interested in hearing from you. So please don't be put off joining ICARA or getting in touch with us if you're feeling as though you're not already part of an organisation or an association for researchers. That's also what we feel is a real important part of our role. This is the current ICARA board. Several of us are on the call here. Obviously, Neo, Tom is going to be our discussant today. I've seen that Matesh is also on the list of attendees, and there may be others that have popped up there as well. We're extremely grateful to the board. All of us are volunteers and working. ICARA has a very small budget, and so none of this would happen without the hard work of these people. So I'm personally very grateful to them also. We are looking for new board members. We will need a new board, several positions will become available from 2021 to 23. So if you share our enthusiasm on the value of connecting researchers and you can spare a few hours a month and would like to grow your own network and profile internationally, please do consider joining our board. You don't have to be part of an ICARA member organisation because you would be elected by ICARA members. You just need to be a researcher working in the field who's keen to help. And we would particularly extend an invitation to early career researchers who would like to get involved in our board. And we have opportunities for you to shadow more senior board members and to get more comfortable in the role and gain experience. So please do reach out to me or to any of our board members in confidence if you'd like to have a chat about what this involves or if you're interested. So just then to introduce the rest of the webinar series, if you enjoy today, it's one of a series of 6, most of which are confirmed now. So they cover the broad range of interests that ICARA covers. So our next one will be curated by our colleagues in Finland and focused on gambling in COVID-19. We will have one then close to the World No Tobacco Day, curated by colleagues in the South African Medical Research Council and Stirling University on tobacco. We have one curated by our member organisation, the International Society for the Study of Drug Policy, that will focus on how COVID has changed cannabis markets, use and policy. That's the 17th of June. We will have one in July, and that focus will be on South America and the Caribbean. The specific topic and date is still to be confirmed. And then we'll finish the series with a webinar on COVID-19 and alcohol policy that's curated by myself with Claire Wilkinson at the University of Sydney. So really grateful again, just want to reiterate Niamh's thanks to our sponsor, the Society for the Study of Addiction. That has enabled us to administer the series in a way that has made it possible. It wouldn't have been possible otherwise. Also, extremely grateful to our speakers today, and particular thanks to our colleagues at the University of Johannesburg, Vuchang Palesa, Hester, Theodora and Cabello. Really appreciate that we are amateurs at this sort of thing, and so you have had to support us more perhaps than might be the case with some other webinar organisers that you work with. So we're very, very grateful for your patience. If you'd like any further information on ICARA, that's our website. Please do feel free to get in touch, and please consider following us on Twitter if you like what you see. So that's really all I wanted to say in terms of an introduction to ICARA and to the series. I'm going to hand you over now to our first speaker, so I'll just stop sharing my slides. So our first speaker is Bronwyn Myers. She's the Chief Specialist Scientist at the South African Medical Research Council. And if I could just remind you that whilst Bronwyn is speaking, if we could, I'll turn off my video, we'll keep our videos off. And if I just remind you that there is an opportunity to post questions in the Q&A, I'll be keeping an eye on that, and we'll have 5 minutes at the end of Bronwyn's presentation for questions specifically on the presentation as with each one. And then at the end, there'll be a time for more general discussion. So very much looking forward to your talk, Bronwyn, which is on engaging people who use substances in SUD services and research during the COVID-19 pandemic. So over to you. Thanks, Bronwyn.
Thank you so much, everybody. And thank you for the warm welcome. Today, I'm going to be talking about how COVID-19 has affected people with substance use disorders in South Africa, and I'm going to be presenting some data that we have from a variety of studies, and with a special focus on substance use treatments and interventions. So I'm really happy and pleased to be here this afternoon. So a little bit of context. So unfortunately, South Africa has the unfortunate reputation of having a high prevalence of substance use disorders. And in Africa is probably one of the countries with the highest prevalence of these disorders. So the most recent evidence that we have in terms of prevalence comes from the World Psychiatric Surveys, and the estimates suggest that roughly about 6% of the general population meet diagnostic criteria for a disorder. Yet despite this high prevalence, the vast majority of people with substance use disorder who want to access treatment do not or unable to attain minimally adequate treatment. So an estimate is that about 2.3% of people with substance use disorders who want treatment are actually able to attain that treatment. And this is pre-COVID. We also have the unfortunate reputation of being a nation of heavy episodic drinkers. On average, people who do drink alcohol consume about 30 liters of absolute alcohol per year, and that puts us amongst the countries with the highest consumption amongst people who drink. So about 59% of drinkers are heavy episodic drinkers. Alcohol is also one of the top risk factors for disease burden amongst adults in the country. It's really one of the major drivers of interpersonal and non-intentional injuries and trauma admissions in the country. And so against this backdrop, when COVID-19 hit South Africa in March 2020, there was a lot of discussion in the health system about how can we minimize alcohol attributable harms and the impact on and conserve health system capacity to address COVID by reducing alcohol use in the general population. The trajectory of the COVID-19 pandemic in South Africa, this slide really just reflects a timeline. And what I want to illustrate is how alcohol use was tackled as a policy intervention, along with various levels of COVID-19 social and restrictions. So when COVID-19 appeared on our shores, the country went into a very extreme lockdown, which we termed lockdown level 5, which was towards the end of March. During lockdown level 5, both alcohol and tobacco sales, formal sales and distribution of alcohol and tobacco were banned, completely banned. And this ban lasted for several weeks until the 1st of June, and it got lifted for a period of time, but because there was sort of a rebound effect with people drinking quite heavily as soon as alcohol became available, the ban was re-implemented around the 13th of July, and the sales ban continued until the 15th of August, when it was slowly lifted again. As the country's rate of infections decreased over time, our lockdown levels became less and less restrictive. But when a second wave hit in late December, a third alcohol sales ban was implemented, and this has only recently been lifted towards the end of February. We are now anticipating a third wave. We haven't quite seen the numbers, but it is a possibility that if a third wave does occur, that an additional further restrictions on alcohol might also be implemented. So what were the impact of these bans on trauma admissions and mortality in the country? So what we did see was that during the period of the first and the second alcohol bans, the weekly deaths from unnatural causes, including unintentional injuries and other forms of unnatural causes, were significantly lower than forecast. So the black line and the graph on the left really shows that the impact of the alcohol bans on unintentional injuries and deaths from unnatural causes. As the restrictions were slowly lifted, we saw an increase in these deaths back to what we would normally anticipate. And then again in the second ban, we saw lower than anticipated deaths from unnatural causes, suggesting that the bans did have some impact on alcohol attributable harms. We also have seen from trauma admissions that as the alcohol bans have been slowly lifted and alcohol has become more available in the community, that our trauma admissions have increased. over time. So it does seem that there's some impact on that these restricting alcohol availability does have an impact on alcohol attributable harms at a population level. But these COVID-19 alcohol restrictions are by nature short-term, and it's highly unlikely that, and it would be, there'll be a public outcry if restrictions on alcohol sales of this nature were to be implemented in the long term. So we really do need to think about other strategies that we can use to reduce the impact of heavy episodic drinking on trauma and on alcohol attributable harms. We do in the country have local screening, brief intervention and referral to treatment solutions that have been tested in effectiveness studies in primary and emergency services. They are locally and culturally acceptable solutions, and they've even been tested in implementation studies, but due to lack of political will, implementation of these services actually stopped about 6 months prior to the impact of COVID. These kind of evidence of the impact of alcohol and heavy episodic drinking on trauma, admissions, and deaths from unnatural causes really can make a strong argument for why these programs need to be reintroduced into our emergency services and primary care. Moving towards people who have more moderate and severe substance use disorders, COVID-19 has also had a significant impact on the lives of people with substance use disorders. And this slide reflects the extent to which COVID-19 has impact on people with substance use disorders. It's extracted from a global survey that was conducted by the International Society for Addiction Medicine. And what you can see is that South Africa, the southern tip of Africa, is one of the countries where people with substance use disorders have been more severely affected. And this is largely because the restrictions on alcohol availability and tobacco availability, alongside severe restrictions on the movement of people, were accompanied by the closure and the pausing of available substance use services, so that individuals with substance use disorders were largely unable to access detoxification, medication-assisted treatment, and psychological and behavioral interventions for substance use. We are now also seeing emerging evidence of the impact of the alcohol bans on individual drinking behavior. Previously, I provided some evidence of sort of a population level impact as seen in our trauma services and our mortality data. But from our studies and treatment cohorts, cohort studies of patients seeking HIV and TB treatment services, we are able to unpack the impacts that these bans have had on individual drinking behavior. So I can present some findings from a TB treatment cohort. This is an article that's in press in the International Journal for Environmental Research and Public Health. And it's a small sample, but in this study, we found that 28% of participants who were drinking prior to the ban continued drinking. 53% of participants who continued drinking said that the ban had relatively little effect on access to alcohol. And this is largely in South Africa because there's a culture of homebrewing alcohol, and there's also alcohol, although it wasn't formerly available in bottle stores, was still being sold under the table and illegally. So, for example, the sale of pineapples to brew pineapple beer, and the price of pineapples skyrocketed during lockdown levels 5 and 4 in the country. We saw that 43% of participants who continued drinking had baseline audit scores in the hazardous or harmful range, largely indicative of alcohol use disorders. And interestingly, although the median number of heavy drinking days decreased for some participants who continued drinking during the alcohol ban, we saw that the median amount of absolute alcohol increased by 37.4 grams per drinking day, suggesting that when people had the opportunity to drink, they really made every use of that opportunity and drank as much as they could. So the ban alone really, for people who are drinking at hazardous and harmful levels or potentially have an alcohol use disorder, is not an effective intervention, and we need additional interventions, including improving access to substance abuse treatment to tackle the alcohol problem in this setting. Unfortunately, we did see significantly reduced access to substance use treatment during COVID lockdown. This slide presents data from the South African Community Epidemiology Network on drug use, showing the number of treatment admissions over since 2018, and the last two elements on the slide on the line reflect January, the 2020, the first half of 2020 and the second half of 2020. So really during COVID. So the 6 months prior to COVID, there was about a halving of treatment admissions during the first half of 2020, as substance use services closed their doors as a result of the COVID lockdown. We've also recently conducted a survey of substance use providers in the country. We surveyed about 70% of providers, and they noted grave concerns about the impact of COVID-19 restrictions on substance use service delivery. A third of providers reported that there had been an increased demand for substance use treatment during lockdowns, especially for alcohol. Most services said they had completely closed their doors in lockdown levels 5 and 4 and had only partially reopened in lockdown level 3 when businesses began to reopen. They tried to provide online or telephonic services to existing clients, but many of the existing clients could not engage in these services due to barriers that I'll mention, and there were no new admissions into services. And when they did resume services, the services were scaled back, so they did not offer group services or family services or aftercare or continuing support services. It was just individual therapeutic contact. They also mentioned widening disparities in access to treatment, specifically for poor and rural populations. So the key barriers that came up were transport and travel restrictions. So patients in rural areas couldn't travel to treatment in more urban areas because of COVID lockdown. 41% reported barriers to telemedicine type services because patients either didn't have data, they didn't have devices, or they lived in circumstances where there was no privacy to engage in therapeutic service. 32% mentioned that their patients had lost their income and therefore couldn't afford treatments. And 16% said that there was a knock-on effect of a lack of detoxification services in hospitals, and also social services and that would refer patients to specialized substance use treatments. So these barriers were also coupled with a range of other factors that increased, in their view, increased risk of relapse for their existing clients. They noted that many of their clients were struggling with COVID-19 related stresses, that they were unable to engage in their usual coping strategies because there were restrictions around exercise and other recreational facilities, the use of those facilities. And then together with reduced support services for substance use recovery, really increased risk of relapse for patients. There's also been worsening health disparities for the most marginalized. So even where some patients have been able to access services and receive telephone support and or been able to engage in Zoom and other sort of virtual interactions with providers, there is a people, by and large in South Africa, people who use substances have been a vulnerable group who've been neglected. And the impact of the COVID responses has probably been most significant for people with substance use disorders who are also struggling with housing insecurity and homelessness. In the beginning of the lockdown, there was a lot of stigma towards people who use substances and who are homeless, and there was a move to take people off the streets and house them in temporary shelters and camps. And at these camps, often access to harm reduction services, including medication-assisted treatment, which is scarce anyway, was severely constrained. So people would go into withdrawals, or they'd need to leave the facilities and camps to access drugs. And so it was really just a hotbed of risk and for the most marginalized. There's also been a reduced basket of health services for people who use substances, specifically related to management of infectious diseases and providing additional care and support to help people who use drugs and other substances remain engaged in HIV and TB treatment. So community health worker, community-based support for adherence and treatment support was really removed during COVID. So high risk and vulnerable populations have been left to struggle on their own. However, despite this quite negative picture that I've been painting, we've also seen this COVID has also produced an opportunity for us to review what we do in terms of substance use interventions and our continuum of care, and to enhance the accountability and effectiveness of services. So with our alcohol bans and a huge public debate around the impact of alcohol on healthcare burden and individual and family burdens, the public focus on substance use disorders has arguably never been greater. It's the COVID response and impact on care has really highlighted the consequences of a long-standing inadequate national response to substance use disorders and long-standing gaps in our continuum of care. So there have been opportunities for people in the field to advocate for greater investment in a broad range of services for substance use disorders, ranging from screening and brief interventions in primary care services all the way through to more access to harm reduction services, including opioid substitution treatment. It's given us an opportunity to rethink our treatment system and think about ways that it can be responsive to the needs of people with substance use disorders in their communities. And then, although telemedicine is definitely not a cure-all or a perfect solution in communities where there's inadequate access to digital solutions and data and privacy issues are real, there are opportunities to be creative about how we can harness digital health to improve access in rural and remote communities. And some providers are really being innovative and are setting up services that allow for virtual engagement of patients in community-based settings and libraries that allow for social distancing, where people can access these services without requiring their own devices and data. And so I think there's the opportunities to engage in debates and advocacies for how we can improve and strengthen our treatment system. So, thank you.
Thank you so much, Bronwyn. That was really fascinating and really interesting to see the differing direction of effects in terms of the positives and negatives of the restrictions that were brought in. I'm not seeing any questions from the attendees, but I have a question for you from one of our panelists, Dr. Maristela Monteiro. Was wondering if was there any increase in alcohol withdrawal or in people needing detox or getting the DTs during the bans?
That's a Great question, and I don't have the answer for it. Unfortunately, the data that we don't gather good data, and I think there's also another opportunity that COVID has really highlighted is the importance of good data collection systems. And at the MRC, we are definitely advocating for better mortality surveillance systems that really unpack and collect alcohol specific information, also for our trauma surveillance. And I think we need better information about alcohol detoxification and the demand for alcohol detoxification as well. So if there is another wave, which I'm sure there will be, and if there's another pandemic, we will be able to report these kinds of information.
That's great, thank you. There are other questions popping up just in the chat, but I'm going to move us on to the next speaker and we'll come back to those at the end where there may be time to discuss them more broadly. But thanks again, Bronwyn, that was really fascinating. If you could stop sharing your screen now, then we'll be able to move on. So the next speaker is actually Dr. Maristela Monteiro, who is Senior Advisor on Alcohol and Substance Abuse at the Pan American Health Organization, part of WHO. And she's joined by Jacqueline MacDiarmid, who's a consultant at PAHO also. So over to you, Maristela, if you'd like to. I'm not sure who's screen sharing, but if we can get the slides up and we'll go straight into your presentation, which is on alcohol and COVID-19 in Latin America and the Caribbean, research and policy implications. Thank you.
Thank you very much. Thank you for the invitation. I'm gonna be sharing the presentation with Jacqueline MacDiarmid, who just started working with me and is also an incredible researcher, and she'll do the second part of this presentation. So what was the situation on alcohol consumption and harms in the Americas pre-COVID? I think that is important to know, and so we can have a better perspective of the changes. Using the global established report on alcohol from WHO and our own, which was published late last year, you can see that alcohol per capita consumption in our region, in the Americas, is the second highest in the world, and is well above the global average, and we follow the European region. And on the left side, we provide an idea of what it means from the total per capita consumption of 8 liters, or almost 2 drinks a day for everyone in the region, above 50, to the per capita consumption only among drinkers, actually excluding those that do not report drinking the last 12 months. And you can see that already on average, every person over 15 who drinks alcohol drinks on average about 3 glasses a day, every day of the year. And that just gives you a glimpse on the how high is the consumption. Of course, it's not everyone who consumes that way. It is very skewed, and those who drink excessively or have episodes or with alcohol use disorders drink the most of the alcohol as well. And a very great gender difference. Men drink more than women, and that is for every country in the region, more often, and on average more. So here you see a snapshot of how the various groups are organized. Of all that, on the left side of all the adults in the region, you have about 57% who are current drinkers. Of these, you have about a quarter that are heavy episodic drinkers, and you have about 9% who have an alcohol use disorder. So it is on average very high, that level of consumption. And it is noticeable the gender differences on the right side, and males and females, how they are compared. And you see among males who drink alcohol, you have 38% who drink in heavy episodic drinking occasions, meaning at least 5 drinks once a month. So that is before the pandemic. That's the situation of the population. There are large differences from country to country, but the pattern of use is of heavy episodic drinking, I would say. So this has, therefore, a very heavy impact, is not only on NCDs, but especially in injuries. As you can see here, we had an average of 379,000 deaths in 2016, representing 5.5% of all deaths in the region. And in terms of disability-adjusted life years, the proportion is higher, 6.7% of all deaths for all causes here. And a great proportion of those are related to injuries, intentional and unintentional injuries. And we have about 3.6% of all the NCD deaths are related to alcohol. And here, this is a reason why alcohol is such an important risk factor for violence and for injuries. As you can see, the proportion of deaths that are related to alcohol is higher, but overall, we are in a very violent region with many deaths related to firearms. We also have suicides, road injuries, opioid use disorders, for example, that lead to overdoses. Here, alcohol or not, it doesn't play a role, but overall, you have that very important role of alcohol in these violent deaths. And especially among younger cohorts, meaning that you have a significant loss in life and productive life when that happens. And in relation, there was a change by accident in that arrow. The arrow shouldn't be there, should be on the left side on the smaller column, but I'm going to explain. The prevalence of alcohol use disorders in the general population divided by sex here is shown globally and in every WHO region. As you can see, the European region has the highest rates of alcohol dependence, harmful use, but in women, so that's the left columns in every graph, the prevalence in the region of the Americas is the highest. 5.1% of women that fulfill criteria for alcohol dependence or harmful use in the general population. That's where I wanted to point the arrow, and that's highest of all regions and globally, and indicates a trend that we see in several surveys in several large countries, that women are drinking more starting as early as men or boys, and continue to increase and have these rates that we now see in the general population of adults. So with COVID, what happened? We have one of the worst situations around the world, is the most affected region by COVID. Now we have the trends with India that are changing rapidly, but that is as of March 25th, and with representing 44% of cases of COVID were in the Americas, and 1.3 million deaths, representing 48% of the global deaths in the Americas. And this is the results of a WHO study that was done in all countries in the world. There were 120 countries that responded to this survey on how mental, neurological, and substance use services were affected during the pandemic. And as you can see, about 60% of all psychotherapy and counseling services were disrupted. And in terms of overdose prevention, harm reduction programs, they were also disrupted at least by 50%. And we know also the impact on mental health of the general population, health workers, was significant and continued to occur. And the services, however, could not respond, and there was a significant burden due to that. So early on, in May of last year, we decided then to understand better what was the situation regarding alcohol consumption during the pandemic. So this was a survey that was implemented between mid-May until the end of June. And we know it was in all countries of the region, in Latin America, sorry, not the US, neither Canada, but all the other countries in 4 languages. And of course, we know also that the results are not generalizable, but when you look at the results with the information that you have already previously, it gives you a good perspective of what was going on. So it was a standardized survey, online, anonymous, and we disseminated through various communication platforms, in Twitter, Facebook, our networks, NGOs that work with us closely, and also individual contacts that could put link in their own Facebooks, for example. And 33 countries at the end participated, and with a very big difference between one country and another. Of course, is a survey, those who responded were the ones who wanted to respond, and it is a non-probabilistic sample. So we covered demographics, COVID-related questions in relation to quarantines, and their also living situation, work situation, how it was affected by COVID, alcohol consumption in 2019 during the pandemic, mental health impacts in the last 2 weeks of responding to the survey, and especially focusing on stress and anxiety. So here the distribution that we got in the Southern Cone, countries responded to the majority, most of the countries, the answers were from those countries. And then Mexico as well was a country that had a lot of responses. At the end, we had 12,328 valid responses. We could not know why the rest out of 23,000 did not continue with the survey. And that is just because the way the survey was organized, because you could immediately need to say, where are you from? And do you want to do this survey? And they didn't move from there. So not even the sex, age distribution, none of the demographics were collected, but we know from the software that people started until that point, but did not answer any question. Here's the age distribution, briefly, young cohort from 18 up to over 60 who responded. And here's what we had on overall prevalence of drinking into 2019 and 20. As you can see, for the total and by sex, there was a decrease in the prevalence of drinking. And these prevalences are higher than the average prevalence of consumption that we have in the region that we know. So more drink answered this survey, so to say, and report an overall decrease. But still, even in 2020 was higher the prevalence than we see overall in the region. And just for the of time, I'm going to give briefly what findings we got. There was a trend towards the consumption in the pandemic of stronger alcohol products. So there was less beer in 2020 and more wine, distilled spirits, and also illicit or informal alcohol consumption. There was that difference was detected. And was also compatible with what the media was reporting, several countries reporting, asking actually for assistance on deaths from illicit alcohol contaminated with methanol or toxin or metals, especially was methanol, and in particular the Dominican Republic, but other countries reported as well. In terms of heavy episodic drinking, we saw that before the pandemic, we were of this cohort, they were reporting between 50, almost 50% of the drinkers heavy drinking, and that was reduced in both men and women, but you need to recognize that these rates are still very high. Was doing in the pandemic, drinking excessively. And here then we decided to analyze how was the change in this heavy episodic drinking pattern, or in the frequency of it. So we got that that about 25 to 30%, according to sex, has decreased their frequency from 19 to 20. We got about 10 to 13% who had increased their frequency from 2019. And no change means here that people had heavy episodic drinking, heavy episodic drinking in 2019 and continue to be so in 2020. So this no change doesn't mean anything better. So you could argue that you could increase, could merge these two groups, and you would see that the prevalence and the situation in 2020 got worse for both men and women. We found that frequency of heavy episodic drinking was correlated with income, meaning those who had lower incomes had a more decrease than no change or increase. We had also those with more income that had more increases in heavy episodic drinking, meaning maybe that they were affording more and could continue to drink that way. Also, we sadly, either before, but that decreased with the pandemic, the vast majority of people do not seek any treatment at all. When they do, they seek on their own to decrease their drinking, but are not seeking any help in any type of service or support group. This is just a brief explanation of the mental health impacts, or on the left side, you can see the questions that were asked in terms of feeling nervous, not being able to control your worrying too much about different things, having trouble relaxing, being restless, easily annoyed or irritable, afraid that something awful would happen, or having trouble falling asleep. And people could answer if the frequency that occurred in the last 14 days, from never up to nearly every day. And this is the distribution that we got. And I'm going to show you here the main findings that we got. Women reported more emotional symptoms, more number of symptoms than men during the pandemic. Both drinking and heavy episodic drinking were significantly associated with more negative feelings. So the higher number of feelings were associated with a higher frequency and prevalence of drinking, but we don't know the direction of that association. The higher the income, the more prevalence of drinking and heavy episodic drinking, as I mentioned before. But having a lower income was also associated with more feelings of anxiety, stress, and trouble falling asleep, despite the fact that we saw the lower income people also had less, a little less drinking and less episodic drinking during the pandemic. And
Maristela, can I just remind you just that the time is running out, so it was just to see if you have many more slides or if you wanted to hand
I'm going
over.
to pass them to Jacqueline to finish up. Sorry that it took so long.
No problem. Thank you.
I think we could just very quickly kind of consider the context that COVID-19 has created around alcohol policy, around research, its impact on people with alcohol problems themselves. And I think maybe to stimulate some conversation either now or later in the Q&A, we can just think a little bit about the challenges that we have as researchers and policymakers moving forward, and how we respond to challenges in the future, whatever that may look like in terms of strengthening support for people with alcohol use disorders. That might include better training of professionals, either in healthcare or social work, on alcohol-related issues, also increasing health literacy for members of the general public. Also, I think it'll be a challenge to regulate online commerce and online marketing of alcohol products, which we've seen an increase of during COVID. And also, I think in general, this is a moment for a conversation about the balance of economic and public health interests, both now and as we move forward. So I think that'll be an interesting conversation, and I'm optimistic that people will be perhaps more open to public health measures that are preventative in future. And I think in general, for promoting, we have an opportunity to promote alcohol policy preparedness for future emergencies, whether they be pandemics or other events that take place, and we can follow in the model of mental health when doing that. So I'll keep that very brief. I'll wrap it up there, and we can continue the discussion, because I know Niamh wants to keep to time, and we have lots of more interesting people to hear from. So I'll keep it to that, and thanks very much, everyone.
Thank you so much, Maristela and Jackie. It would have been lovely to hear more, but I'm conscious of the other presenters, and also to protect some time for discussion as well. So there have been a couple of questions, and I've been making a note of them as we go along. So I'll come back to any questions that we haven't covered in this part of the webinar. I'll come back to them at the end. So I'm just going to move us on now to our next speaker. I think there's been some really nice synergies between Bronwyn and Maristela and Jackie's presentations, and I'm sure that this will also add to our understanding. So Dr. Florence Baingana is going to speak to us now. She's an advisor at the World Health Organization in Brazzaville in Congo, and will talk to us about addiction science in the African region pre and post COVID-19. So over to you, Florence, and thank you very much.
Thank you very much. As has been mentioned, I believe mine will also complement what others have already said. I'd like to thank very much the organizers of this meeting. I have found it very useful to be a participant, and I have learned a lot. The key messages, I have 3 key messages that I'm going to present today. One is the disconnect between the programmatic data and published data. The second one is the disconnect between pre-COVID-19 and post-COVID-19 research carried out on alcohol in the African region. And the third one is there are opportunities to use routine data to track relationship between COVID-19 and alcohol use disorders. So I will get right into it. First of all, the data that we often use and which has already been presented here, what do we use as WHO to track progress in implementation of the global strategy to reduce the harmful use of alcohol? Most data sources are from STEP surveys. Some are from published journal articles, but when you go in to look, for instance, at the link that is provided below, you'll find that most countries actually are not using data from published journal articles, and I'm not sure if it is the countries or it is the WHO that looks at the studies that are included and determines on whether they are strong enough to be included or not. And for some of the countries in our region, a lot of the information is also estimates provided by the countries or estimates developed by those who put in the data in the Global Health Observatory and GISA. So that is one. Also, in the middle of last year, from about mid-June to mid-August, we did a survey to look at the impact of COVID on essential mental neurological, essential mental neurological and substance use disorders by settings and categories, and different aspects were looked at in this survey. This is the sub-analysis for the African region, and only one aspect of it looking at closure. For instance, how many of the services were closed because of the COVID. And as you see, general hospitals, especially inpatient services for substance use, were the ones that had the biggest number of closures in our region. So anytime that they had to repurpose a service, or they decided we need to close a service because of the risks of COVID, substance use was one of the first services that was closed, substance use service. And looking at causes of service disruptions, these were also touched on by Bronwyn, and they look very similar to what we found in that survey. The darker bar is the global, but the paler blue one is the Africa region. So one of the biggest causes of disruptions in the Africa region was the decrease in outpatient volume due to the COVID. But then the second one was travel restrictions. So people not being able to get to the treatment facilities. And this is in general, not just for substance use disorders in general. But of course, we know that this also impacted substance alcohol use disorder treatment programs. And the third was the decrease in inpatient volume. So very often when people have to prioritize who is going to be taken to the hospital, you'll find that those who have alcohol or drug use disorders are not going to be prioritized as an emergency. They will often say, well, this one can wait until the emergency is over, the COVID is over, and then maybe we'll be able to take them for their follow-up visits. This looks at total alcohol per capita consumption. And as you will see, the data may be a little different from what was presented earlier, but for total alcohol per capita consumption, for instance, the highest rates in the region are for Seychelles, and then we have Uganda, Burkina Faso, and South Africa isn't quite high there because this is looking at the total, not looking only among drinkers, so that may be why. But it also could be the data sources that are being used for this data as opposed to what is used for the data that was presented earlier from South Africa as an example. I think what is also of big concern for us at the regional office is the number of young people who are consuming alcohol. This shows 13 to 15-year-olds. Can you imagine 13 to 15-year-olds who are consuming alcohol? And you find that in Zambia, 42%, that is almost 1 in 2. And if we are to stretch it, it would be 1 in 3 are consuming alcohol, and the numbers they are going down to the 11th. But I think for me, the big concern is these numbers that are over, 1 in 2 young people consuming alcohol. And these are the young people who are often targeted by the alcohol industry and the poor regulations in our region. And these are the young people who then grow up into adults with alcohol use disorders. So Africa pre-COVID and alcohol publications, when I did a very, very quick search, but it's quite rich. You actually find a good number of articles and all types of articles and all types of countries, not every country, but a good number of countries from the region, and also very different study populations, including breastfeeding mothers, pregnant mothers, young people. There's lots of studies on young people, but it's quite varied. There's also a focus. These articles tend to focus on prevalence rates as well as clinical presentations, but also risk factors for the different populations. But there's not so much on systems and implementation science. So for instance, I don't think I saw anything, for instance, on AA in the African region. How is it running? How many countries have programs? How effective are they? And then alcohol treatment units. We have a lot of alcohol treatment units, often set up by those who have recovered. So those who are in remission turn around and set up these alcohol treatment units, and I don't know how they are being regulated, and if any work is being done on that, how they are regulated and how they are being run, and how effective are they, and the cost effectiveness of the alcohol treatment units, because they actually run as a business. And then the other one is the non-health interventions and impacts on alcohol use, because as WHO, we have the SAFER package. The SAFER package includes 5 different areas that are the best buys for managing, for trying to decrease the harmful use of alcohol. And only one is screening and brief intervention. So the other ones may not be health interventions. And I did not see so much on those other non-health interventions, such as taxation, drink driving regulations and policies, and other things like that. So if we look at post-COVID alcohol publications, there are very few publications out of Africa. Most of them were South Africa, and some of them were quoted here today. But other than South Africa, I really did not see very much coming out of Africa post-COVID. There has been some reports globally that seem to indicate both an increase and a decrease of alcohol consumption reported from other parts of the world. So some people say because of COVID, some people chose to drink less, but then others, unfortunately, due to the stress, were actually drinking more. There was one interesting paper from Zambia that I show, which shows a link to NCDs, including alcohol use disorders, as being linked to excess mortality. So this looked at postmortems. There's also a link to heavy episodic drinking, especially among young people and those who are stressed. I think they also mentioned an increase among women. And I think what was touched on by Jacqueline, online marketing, online sales, there's a lot of anecdotal information on that. Home deliveries and curfew. A lot of young people, because of the curfew, are throwing all-night parties, and they order and get the alcohol delivered to their homes, and then they party all night. And so this also increases the heavy episodic drinking among young people. What could be hindering research on alcohol in the African region? I would say alcohol is not yet prioritized for COVID-related research in the African region. We have focused a lot on research that tries to understand the impact of COVID. Even mental health research, yes, there's some of that, but alcohol is not often considered to be a priority, and so not yet prioritized. I think researchers and academicians also are repurposed to COVID-19 work, or the researchers and academicians take advantage of the available funding, which may not be prioritizing alcohol, and therefore they gravitate to where the money is, and that too is understandable. There has been closure of academic institutions, and this may have impacted the ability to initiate new studies, especially in relation to alcohol and substance use disorders. Available research funds cannot be changed to COVID-related research. Very often to change and move it to something else is very difficult, but there are some research opportunities. For instance, HIV, AIDS, and COVID and alcohol. There are some of those opportunities, and I'm not sure if they are taking advantage of that. Potential areas and opportunities for research in alcohol include use of regular morbidity and mortality data to analyze and determine the link between alcohol and COVID-19. For instance, liver disease, for instance, that study that I talked about that was carried out in Zambia. The other one is the potential to use global funds to do alcohol, HIV, and TB studies, because that window is actually there. And then we need to remember to include implementation science studies and health system studies, as well as the clinical studies. I think there's a very strong leaning to the clinical and the prevalence, but we really need to do much more of the implementation science, especially for our region, to understand what is it that works best in our region to manage alcohol use disorders. And then there are also the multi-sector studies, for instance, impact of marketing and online sales on consumption. Thank you very much.
Many thanks, Florence. I really appreciate that. And thank you so much for keeping to time as well. So our next speaker is Jennifer. I see you're all set, Jennifer. Thank you very much. Jennifer is Dr. Jennifer Gonzalez, to give her her correct title, who's Senior Director of Population Health at Meadows Mental Health Policy Institute in Dallas, Texas. So a very different part of the world. And we're going to be really interested to hear you talk about the effect of COVID-19 on research with homeless and justice involved persons in the United States. So thank you very much for making the time.
Yes, thank you. I am very excited to share some of my logistical issues that I've run into and very practical concerns that I have with our data. And so I'll show you some data today for two of my studies that have been ongoing. They're in both year 4 and year 3 of 5-year cycles. Both of them have been severely impacted by the pandemic. And so I'll present to you some data on recruitment, retention, some substance use measures that we have pre and post. And I'm hopeful that you all can help me explain some of these trends. So I look forward to this. Just to give you an idea of what we're talking about again, we'll talk about the practical challenges of COVID-19 and what they've presented for behavioral health research with 2 groups of vulnerable populations in the US. So the first group that we'll talk about is a sample of homeless adults they're in the Texas area. They are justice involved and were recently released from jail and in need of some services. We'll presume that all people who are homeless do need some service or another. And so the goal is to link them to services through the use of a smartphone app. The second study is an expansion of medication-assisted treatment for people who are coming out of jails. So instead of having them sit in jails and wait for and detox there. The goal is to rapidly remove them from incarceration and put them into a treatment setting where they can then receive an evidence-based treatment, which I don't know how it is in the rest of the world, but in the US, even though everybody knows that MAT is the gold standard, very few people actually receive it. And I think that would be especially the case among incarcerated populations. And so we're studying the implementation of this, as well as some preliminary outcomes, things like relapse and success in their treatment program and such. So I'll talk about the studies just a little bit so you can fully understand what we're looking at here. In the first project, the sample with homeless adults, this is an NIH, the National Institutes of Health funded research study. We're in year 4, close to being in year 5 of 5 years, and we are not anywhere near completing the study. We were just a little bit behind until COVID happened. So the goal was to have 432 people enrolled over the 5 years. We currently have about 250, and we had about 220 before COVID happened. So all these people were released from a jail, which we verify in the past 60 days. And those people they come in person to a homeless shelter where they complete 6 in-person visits over the course of 6 months. So at a second visit, they are randomized into one of 3 conditions. So the first condition is a treatment as usual condition, where they don't get a phone. If they have a phone, that's great. And we record all their information, but we don't give them a phone. They get care as they would normally get it at a shelter, whatever facility they might be attending. The second is a smartphone only. So we provide participants with a smartphone, and it looks very much like this app on the far right here, but it does not say call my care manager. It just has some bus routes and some helpful websites, like where the NA and AA meetings occur and what times they are, things like that. It'll remind them of when their next in-person appointment visit is and how much they'll get paid when they come. As well as it'll have a call staff and a call crisis line, which links them to a behavioral health crisis provider. So they receive the smartphone, but not any intervention per se. Then the experimental group, they receive a smartphone plus an intervention. So they get this app, which collects data twice a week. We pay them to complete ecological momentary assessments, which are just very short phone-based surveys. But also it prompts them, based on their responses to these assessments, it prompts them to say, we think you need care for this. Do you want to call your case manager? Do you want to talk to this treatment provider? Do you want, and tries to link them to care through their phone. So that is the intervention that we're testing here. So the main outcomes of this is to get them to use more services, which just by linking them to services, making it easier for them to access them. Fortunately, all these services could be administered through the phone, so they were remote to begin with, which was nice. We ultimately hope to have people get out of homelessness, have more social support because they have this phone, they can talk to people and theoretically feel more connected. We hope that they'll use less substances, especially if they enroll in more substance use treatment and related, less psychological distress and behavioral health concerns. And hopefully they go to jail much less. So they're not involved because they're not involved in as much criminal activity, they're not arrested. And so hopefully we save money in the long run because jail is a very expensive way to house homeless adults and not the most efficient. So let's talk about recruitment, which was the biggest issue for us with COVID. So if you look at, this is by year. So the green is the first year we started. You can see it took a little while to kind of ramp up. And there's cyclical effects, like we recruit much more effectively in the summer to the fall, especially in the summer, fall, very early winter, and then things decline. It's very odd. So in 2021, which is the red line here, you can see we were doing really well. We started off the year, everything was good. And then in March, we just go to zero. We go, well, we had a couple in March. These are new intakes into the study. And so through June, we had nobody, April, May, June. And so, you know, when you're recruiting people on site, everyone on site at a very large homeless shelter. Everybody there knows your face, they know your name, new people are referred to you. But when you stop that really abruptly, it's very difficult to regain momentum. And so you can see we started again in July, recruiting some new folks, and we barely ramped up to where we were. If you look at the black line on the far left, it's we're still kind of where we were at when we restarted data collection. So it's been very difficult to ramp back up to where we need to be to actually finish the study, which is a bit concerning. It's also problematic that there were shelter lockdowns at this time, so we couldn't like go and find people for new assessments like new intakes like we normally would. Like we'd go to other shelters or staff and kind of meet new people and find out if they're eligible, do an informal screening. Hey, come visit us. You know, you could be in the study, get a phone maybe, or get lots of payments, which people are always wanting. So this is a major concern for us moving forward, one that we aren't sure how to resolve. The second big concern, which has not been as much of an issue as I was expecting it to be, was participant retention. So we have the completion rates here for 3 of the follow-up visits, pre and post-COVID. So the dark blue is the pre-COVID completion rate, and the post-COVID is the light blue. And you can see that they're almost on target, pre and post, which is very surprising to me. And I suspect that people who were homeless were not, perhaps they weren't as impacted by the financial effects of the pandemic as maybe other people who had jobs, or so many of these people do have jobs. So this is when it's kind of hard to explain, but I'm happy that we have this problem. So one thing that we did do at the beginning of the pandemic, because we didn't want to have a ton of missing data on follow-up interviews that needed to happen, was we got IRB approval to do phone surveys right away. So it's a very long survey. This was very difficult for my staff, but it was an hour and a half long interview that was previously done on a Cassie on the iPad, and it would read the participant the question, and the participant would select the answer, which was private. It was really easy to administer. But when we did them over the phone, my staff had to listen to the question, read the question to the participant, then answer the question for the participant over the phone, which was certainly not ideal. But that was one way we hopefully at least retained some people in the study. And then we also added our RedCap, which is just a remote way of collecting data. It's an online survey. So we would send a link to our participants or text it to them, and they would complete. And we've had a lot of success with that as well. But when we do surveys remotely, there are some collateral consequences. So we have people come in for each of our visits, and they get some clinical measures: height, weight, waist circumference, carbon monoxide level is a big one to see if they're smoking or not. And you could see the carbon monoxide monitor does malfunction every once in a while. So we had a little bit of missing data pre-COVID on that. But as you can see, the post-COVID percent missing, every remote interview essentially had missing data because we couldn't have people, we couldn't record these measures for those folks. And we're worried that this could impact some of our statistical power as we start to put our models together in the future. Another thing that we do in this study, and this is just kind of where we are freestyling a little bit here, but we measure alcohol, drug use, and homelessness status using the timeline follow back, which I'm sure many of you have seen, but I show you here. This has some visual aids associated with it. So you could see it defines for the participant, it gives them a calendar so you can like remember what day was what, which was the weekend days, and hopefully recall more clearly how many drinks you had on each day. And then remember, refer to these standard drink calculations, if you want to call them metrics, whenever you need to. But when you're doing that on the phone, it's not available to you. So we also provide these standard drink we provide these calculations here. So for our staff, which is not, there's just going to be much more bias here in this timeline follow back. Our staff is also concerned that participants are not as willing over the phone to like deal with this process because it's very cumbersome. So how much did you drink on this day? Well, what that day would you say it was 4 or 5 drinks on Wednesday? And so we're doing this for 90 days sometimes. So when you go through 90 days of how much did you drink on every day, it can become very difficult over the phone, especially when someone's on the train or they can't hear you or they're on speakerphone. So it's more logistically complicated than I was hoping it would be. And so since this is currently the gold standard way of maybe alka sensors are the gold standard now, but this was in the past the gold standard way of measuring substance use. I'm concerned about the validity of administering these over the phone. So now let's switch to the second project, which is the MAT expansion for justice-involved populations. And this is currently in year 3 of 5 years. It's doing much better in terms of recruitment. But we have about 200 men and women in this project. That's our goal. We currently have about 120 or so that have been enrolled over time, which is good. We're right on track. The goal of this project is to describe the implementation of MAT use and its effectiveness. So is it helping people who are these people happen to be in specialty courts? Is it helping them to complete treatment compared to people who don't receive MAT? Is it helping them to relapse less often? Like things that we are pretty sure we know are true, but just to make sure the implementation is working as we expect it to in a justice-involved population. And they're all currently under the supervision of the courts. So they're receiving drugs in hopes that they will not use other drugs. So this was a little bit of a stretch for justice leadership to really understand and get. So that's why it took a long time to roll it out. So we collect data longitudinally. So we'll get it right at when they're intake to treatment. So hopefully after they've detoxed, which usually happens in jail, unfortunately. And then 6 and 12 months after that date, just to track relapse and other self-report measures. But in addition to self-report, like substance use, which of course we'd use to measure relapse, we receive urinalysis test results from the probation department, and that tells us which drugs they've used and which combinations of drugs for all tests. So we have several of those for each participant. Some clinical diagnostic information. So if they had a co-occurring behavioral health disorder at intake or discharge from treatment, whatever is in their clinical record, we would receive. If they had been rearrested over the 12-month period that we were following them, we've received that information in addition to what their charge is, and a success in the court. Do they complete treatment? Do they complete their court program? What are the good things that happen? So referral was not as much of an issue in this study because people are just constantly coming to jail and in need of MAT. They were being referred to the study. So you could see in February, March, we had 0, which was a little bit unusual, but not atypical. There's some random patterns in the data for referrals that they're funneling into us from someone else. And then we had referrals increase over April, May, and June, which is nice, except that treatment facilities had closed. So that one of them had a COVID outbreak and the other one was just closed to new referrals as a precaution. And so these people were just sitting in jails, just waiting for a bed to open up that they could occupy. And so let's talk about the urinalysis test results. So this was one of our primary outcomes. It's our objective measure of whether or not somebody is using a substance. You can see the green is the pre-COVID rate of testing, and the rate of positive testing is on the right in the blue. So the number of the proportion of participants with a COVID test completed was more than half. So we had urinalysis tests on way more than half of people. That shrunk to roughly a third post-COVID. So people were just not receiving any tests during this lockdown period. I believe they started retesting again in the summer. But between March and June, there's not any test results for any of our people. But also the rate of positive tests had declined. And so this is one of the unusual findings, is 22% pre-COVID had a positive test versus only 16% post-COVID. So this could indicate to me that either substance use declined, and in my first study that I discussed, the homeless adults, we did also find that self-reported alcohol use had declined substantially by 2 drinks per episode, and I can't fully explain that. So I wanted to, there's been a lot of literature showing that it has increased over time. So why in this population it just appears to be declining, if that's what's actually happening here, I'd love to hear some more about. Our response rate situation has been really good. So on the left, the pre-COVID situation at the 6 and 12-month follow-up, which was not good, especially for the 12-month follow-up. And on the right side, you could see the rates were about roughly the same for 6 months, and then increased, more than doubled, and probably because our rate was so bad pre-COVID. And so we really got vigilant about following up with people and staying in touch. And so I think it was a good awakening for us as the research team to make sure we were staying on top of people to minimize missingness in our self-report data, because we knew that was all we were going to get. We weren't going to get any urinalysis test results. So these are kind of co-occurring things that have happened right before I summarize, that are not necessarily related to COVID, but they are related. Well, one of it's related to COVID, one was not, but they are related to alcohol research. And so the first one is that because we were using smartphones, we were tracking where people are, where they were going. And so we haven't, in the past, what we've done is added on some sort of intervention for people to, when they neared an alcohol outlet, they received a prompt or some kind of intervention in an attempt to reduce their likelihood of going into that alcohol outlet and consuming drinks. And that was called geofencing. So when they enter like the area around this outlet, they would get some sort of notification. But with home delivery of alcohol, which I know our previous speaker mentioned, it's been very difficult to this. And I know these people are homeless, but people will get home delivery of alcohol to anywhere. So it's not necessarily your home, it's just delivery. And it's very popular in both of these populations. And so we're really concerned about the feasibility of those approaches moving forward. And second, this one was a really big deal for us, is Google stopped allowing us to collect participant GPS data. This has nothing to do with COVID, but it happened at the same time. And so it's really unfortunate that we're not able to look at where people are going and how they changed in their patterns of behavior and where they travel, who they go see, their associates, because we can't collect that, even though the participants do consent to it. Google threatened to remove us from the App Store if we did. We did not remove that capability. So just to summarize, we have fewer, the summary of the impacts, or we have some fewer missing data issues than we had expected, except for the clinical measures. So it'll be really interesting for us to see if the clinical measures are going to impact the findings of substance use trends over time. We'll have to rely more on self-report or think of some way to handle all this missingness that we have. This multiple imputation methods won't work so well if we think things changed post-COVID, which I think that they did. Retention has not been impacted that much, which is nice, but I think that has been impacted by our preemptive measures with using red cap and phone interviews and just being more vigilant about retaining people in our study. In terms of recruitment, this has been a primary issue, and it's difficult to regenerate the momentum here. And I think a lot of researchers are in this boat. And so it'll be interesting to see if we are, I'm done after this, I promise. If we receive some additional funding to complete our study, or if we're needing to terminate prematurely. So that's all I have. Oh, and thank you all for listening.
Thank you so much, Jennifer. That was really interesting, quite different to what we've been hearing earlier, but obviously some overlapping themes as well. So really, really appreciate that. So I'm going to move us swiftly on to our discussant, who's Professor Tom Babor, who is professor at the University of Connecticut, who's going to draw together some of the themes that we've been hearing, and then we'll move on to our brief discussion before we finish for the evening. But thank you again, Jennifer.
Yeah, I'd like to reiterate the thanks to the speakers. We've got a fascinating panoply of observations about the pandemic and its interaction with alcohol and with addiction science, and how it's affected addiction science, and how addiction science has made it possible to learn more about the pandemic specifically, and in general, learn more about how alcohol-related problems and substance abuse are affected by massive global disruptions in lifestyle and health. So there are a variety of things to talk about here. We know that alcohol exacerbates risk-taking behaviors and health concerns, mental health problems. And we also are in a global situation where alcohol consumption is stabilized or declining in many high-income countries, but it's increasing in low and middle income countries. And the focus in this webinar, which is particularly relevant globally, has been on low and middle income countries, particularly in Africa and Latin America, but also, as we've heard, the issues related to underserved minorities in high income countries. And in a globalized world, with a globalized alcohol industry, with a globalized pandemic, we have a perfect storm that's going on in terms of lifestyle disruption and its impact on substance abuse. So the themes in this webinar cut across these issues in a very important way. The first issue that I see as a theme is COVID-19's effect on alcohol use primarily, and on other substance use. And it seems to be different in different countries. There have been some surprising findings, like from the PAHO survey, of an overall decrease in consumption. We've learned from South Africa and Congo and other African countries that the effects can be time limited, and they seem to depend on a variety of different factors. It's not a simple effect of the pandemic on drinking. It depends on the overall policy environment, which tends to be weak in low and middle income countries. It depends on the income level with a given subpopulation within a given country. It depends on the substance use history within that country, as we've learned about Latin America, and the support systems that are available, including treatment and prevention. We have another theme here, which is the challenges to access to treatment and other services. The effects of the pandemic on treatment delivery in many countries have been profound. And we're still in a position now to begin to learn what happens when you restrict access to treatment. At the same time, you're either restricting access to alcohol or making a more availability in a different setting for home drinking. We're learning about health disparities, gender, racial, ethnic differences, homelessness, and how the pandemic has changed the way that treatment is being delivered and how it's adapting to these challenges. So one of the ways that that's occurring is through the use of telemedicine and a variety of new technologies, including in the research area, spatial analysis, to try to monitor people and warn them of high-risk situations. We're learning about new services that are emerging. And out of the major challenges that we've witnessed, there are also then opportunities. A third theme is the effectiveness of policy or the ineffectiveness of policy. And Bronwyn and Jacqueline and Florence have all touched on these issues. The effects of the lockdown in changing availability, and then the adaptations that have been implemented personally and by the industry to get alcohol into people's hands when bars are closed. The bans in South Africa on sales had an impact which varied over time. And we're starting to find out how restricted access through these natural experiments are capable of changing the way people drink and the health problems that they experience. The final theme is the challenges to research, and certainly Jennifer has gone into depth about that, but Florence has already touched on it as well. The challenges are particularly acute in low and middle income countries, which have experienced at the same time major service disruptions. But again, the creativity that we've seen manifested here in developing new ways to adapt research to answering very important questions has been impressive, even at a time when funding has not responded as rapidly as it should have. So the research community is to be, particularly in addiction science, is to be congratulated, just as we've seen the impressive response of the global scientific community to develop new public health measures, social distancing, for example, new vaccines. We've seen these kinds of adaptations in the area of retooling our addiction research capabilities and adapting to the challenges to respond to the threat of this global pandemic. And it is quite possible that the way we do research is going to change. The way certainly people are drinking is beginning to change, going from public to private settings. And what we're hearing is if we are going to respond better in the future to pandemic situations and major catastrophes, including the impending threat of global climate change, we're going to develop or need to develop better research methods, responding quickly to natural experiments. As Florence suggested, we need better surveillance systems that are already in place so that when these changes occur, we can monitor their impact. So there's a lot to learn from these presentations. All of them, I think, have contributed not only to the progress of addiction science, but certainly to our understanding of the global pandemic. So thank you to the speakers for your contributions.
Thank you very much, Tom. If I could just invite all of our panelists just to turn their videos back on now, and we'll just take the last bit of time to have a little bit of discussion. So I've been collecting up questions and thoughts based on what's been in the chat and other comments that have been made. And I just wondered if we could start off by just picking up on one of the points that was made by Florence. And if I could just ask the panel if you think that there are ways that we could advocate better for research on alcohol, tobacco and other drugs to be able to access COVID-19 research funding. How easy has that been where there's been an investment in research that's related to COVID-19? Can we make a case to access that funding for ATOD research?
During COVID, there were a lot of resources made available internationally, provided that they were related to COVID. And that was tapped and used, and it differed from region to region. In some regions of WHO, I mean, it was you had to go through selection or a committee that would screen what could be done or not done, and in others was much easier. That's how we got a little funding to do. But also, it was unfortunate that we couldn't. That I went over time, but also that the quality of some of the research proposals were not always good, because of they wanted to tap as soon as possible on that grant, on that ability, on that funding, and therefore, proposing just poor questions, and that would not lead to much. And because it was COVID, everything was also approved. Not everything, but a lot more than usually.
Okay, so in the rush to secure funding, sometimes it's difficult to maintain the quality of the proposals that are being made.
Yes.
Interesting. Okay, thank you. We had another question from one of our attendees, Erica, who was wanting to ask if you could advise on improving access to substance use treatment in rural communities. If anyone would like to come in on that.
I can speak briefly to that. Actually, not from my experience working in the Americas region, but previous to this, I was working in Scotland on a research project with regards to supporting people with alcohol problems in rural communities. And it was really interesting doing so. Like, I think similar to the experience that Jennifer had, that research was very interrupted by COVID initially, but then we experienced, I think in a way the study changed, but in some ways might have been improved by just kind of like greater access because of COVID in a contradictory way, because people who probably wouldn't have been able to come to in-person events or make themselves available, even though we were planning to travel around Scotland still because of the distances involved. I think changing to a totally virtual or by telephone research, strategy, that was good. And then many people also said that, like, where previously they wouldn't have been accommodated for telehealth, they were now being accommodated. And I think it just went to show that we can be much more responsive in the future and much more flexible. And I think what comes with that is a commitment to people who either don't use the internet because of age or other access issues, or if you're in a rural community, also sometimes access to good quality broadband is an issue. So I think while telemedicine or virtual medicine can be good for rural communities, it comes with that extra bit of having to invest in, people who have to invest in good internet, and you have to make sure that it's accessible to everyone as well. So that's a thought that I have on that subject.
So we have been really successful, at least in the state of Texas, at expanding telephone only. So video is not required, and hopefully that will continue post-COVID. My organization's been working hard to get that, to make that one of the provisions that needs to stay, like long-term, so that people don't have to have that video. But also with substance use treatment, another big issue is the deregulation or more loosening the restrictions around medication-assisted treatment. So buprenorphine is a big one. So I don't know, I tell people like, we should just be dropping this stuff from the airplanes. Like, we could just everybody have buprenorphine. Like, why would we not? So right now it's pretty difficult to get, and the providers have to get a certification in the U.S. to be able to prescribe it. But if we let everybody prescribe it, primary care physicians, or just let people go to the CVS, whatever, CVS drugstore, whatever drugstore you have, keep it behind the counter with the Sudafed, and then let them purchase it themselves. Then that would be a major Kickstarter, I think, for rural areas.
And Jennifer, while you're unmuted, if I could follow up, that's really interesting, I think, and some really good suggestions there, and probably things that would translate to low income countries as well, in terms of just telephone access, where there's quite high levels of smartphone usage in lots of countries in some of the WHO regions that we've been hearing from. But I wanted to ask about the geofencing, and I was wondering about the alerts that you talked about, where people come near to an outlet, and I wondered if that is being done in more rural areas. I was trying to think how that would translate in Scotland. I think we would be getting alerts all the time because there are just so many outlets. So I just wanted to ask, is that, what's the sort of average frequency with which people get alerts, and does the change in Google policy mean that you won't be able to do that in future, even if it's no longer home deliveries?
We can't do it now. Yeah, unfortunately. It happened a month or two ago. It might have been even long before that. But they've totally stopped our ability to record GPS data. So we're recording it every 5 minutes. So if you came within, I believe it was 100 feet of an alcohol outlet, you receive a prompt for the intervention group, and they do not receive those now because we can't record that information.
Have you had feedback from people who miss them, who found it useful previously? Do you know anything about whether it's a real loss to your participants?
Not yet, because we do those exit surveys at the last visit. So I don't think we've had enough time since we've removed them to get people to that 6-month point.
Great. Okay. Thank you. We'll look forward to hearing. Really interesting. Yeah. So I want to also invite the panelists, if you've got any questions for each other or comments that you'd like to make based on what you've listened, feel free to jump in, and I'll just have a little look at my notes to see if there's anything else I've missed from the participants.
Maybe you can just quickly jump in to ask.
Yes, great.
My colleagues from Africa, South Africa, maybe. I'm just wondering about this idea of treatment and reaching the rural areas, because for somebody to go into treatment for alcohol use disorders, they have to choose to go in. But then I find that for most of us in the African region, maybe I'm mistaken, but it's the parents or somebody else, the wife or somebody who forces you to go into the treatment facility, and then they kind of keep you there like a prisoner. And so the rural areas don't really have these treatment facilities. And I don't know what is the experience then for South Africa, which may not be the same as the rest of ours. But I feel like if it is the individual making the decision to stop drinking, it would be easier then to do the phone. But because it is not, very often people are forced in and locked up in these treatment facilities. Yeah.
I think the South African experience might be slightly different. So we have very few inpatient or residential treatment facilities. Most of our services are outpatient or ambulatory. And yes, there's a pressure to enter treatment, but for the most part, it is voluntary. There are really severe restrictions on access for individuals in rural and remote regions of the country. And for those individuals, they often travel to other provinces, in some of our more rural provinces, to receive treatment. So COVID came along with intra-provincial travel restrictions. There were no flights, so those individuals really suffered. I do think that our statistics suggest that mobile phone penetration is good, but the reality is that in many households, a phone is shared. And a phone is a commodity, and it's also sold when money is short and phone numbers change. So for some we've had a study working with adolescents actually, and we tried to change our counseling from in-person to telephonic, and it's just been a major challenge. And we're now trying to use a hybrid approach. But I do think that there are opportunities to use digital health or telemedicine and build off the infrastructure that is available in rural communities. So in most parts of South Africa, generally a rural community will at least have a community health center. It might be tiny, but there's a community health center. And a community health center does have some infrastructure, and perhaps that could be a place for video consultation with a provider based in a more urban setting. And we can think about creative ways of providing access to substance use treatment that isn't necessarily facility-based, specialist facility-based. And maybe that will also reduce some of the stigma of having to go away to substance abuse treatment.
Great, thank you. That's really interesting. So I'm going to try and wrap things up and just maybe give you a little taster of some of the other questions that we haven't had time to really discuss in detail, but I think that we're going to pick up again in several later webinars. So particularly the issues around alcohol, which is my own area of interest. I know that we're picking that up in the very last webinar, but probably also in the July webinar, which is focused on South America and the Caribbean. So I think there's still a lot of thinking and understanding to be gained around what is the interaction between the policy situation, COVID-19 impacts in terms of, so alcohol policy, COVID-19 policy and restrictions, and on different drinking groups and therefore on different harms within the population. So I was really interested in thinking about what is generating a reduction in alcohol-related visits in emergency departments if people who are very heavy drinkers are still drinking the same amount. Does that mean that most emergency department visits are generated by non-dependent drinkers and it's acute traumas that are being reduced potentially, where the sort of traumas related to continuous or heavy drinking are still at that sort of baseline level? Or is it that there's something else going on in terms of the interaction between off-license drinking and drinking in bars and pubs? And I know in some countries the bans on sales have only applied to bars and pubs while off-license drinking has continued. So that issue around about what's the balance of harms, and should we be trying to protect bars and pubs in order to reduce home drinking, or does that just come with other harms that we don't want to incur? So I think lots of food for thought across the presentations around those alcohol issues, but as I say, we probably don't have time to get into them now, but I'm sure that we will in further webinars. I'll perhaps just finish there, but can I just thank all of our speakers again? Can I thank Tom also for really insightful comments and as a discussant, and Neo and all of our colleagues at the University of Johannesburg and everybody who's been involved from ICARA, and also just a final word to thank the Society for the Study of Addiction in the UK for their sponsorship. So I hope that everybody has a good weekend when it comes, and thank you again for your participation.
The University of Johannesburg, the future reimagined.